I want to announce, since I said I would, that the two code words for your virtual CLE credit, and I'll say it again a couple of more times during the day, is hybrid and enterprise. Let me repeat that: hybrid and enterprise. Okay, we're now ready for our next panel, which is a great follow-up on Juliet's talk. And by the way, we'll get to see Juliet again because she's going to be in a panel. We got her here all the way from New York, so we wanted to utilize her as much as possible. So the next panel on creating a success, on lessons in negotiating, evaluating value-based contracts. So can Christine and Kristen come on up and we'll get started. And I'm going to sit over here because there are only two of them, so I can sit right here. I'm not going to take a lot of time to give you the background of Kristen and Christine, other than to say, because you've got material, but I can tell you that Kristen is with Carrum Health out of San Francisco. Yeah, all the way from California. And and Christine Worthen is actually a partner at Nelson Mullins. She joined us recently, and prior to that, she was general counsel for Northern Lights Hospital System in Maine. So today they are going to talk about actually a real deal, a successful strategy in negotiating value-based contracting, which involves bundling. So I'm looking forward to it. I've been looking forward for a while because I know they both know their stuff. So I'd like to start out by asking a question. And hold on one second so I find my questions. Here we are. Christine, I'm going to start with you. I want you to, I'm asking you if you can provide an overview of your experience in the MA value-based contracting space and give us some practical tips that you can share for providers.
All right. Can everyone hear me okay? Yeah, can we launch the deck? We're just going to wait for, I did prepare some slides to help you kind of follow along.
It's like they're up. No, they're not up.
There we go. All right. So good afternoon, everyone. Glad to be here with Kristen, with whom I have negotiated a bundle arrangement. So it's always fun to come back and sit next to her. And in terms of answering Mike's question, and what this presentation will cover is both the legal and the strategic considerations. And we're going to drill down into two value-based contracting opportunities. I'll just briefly go over the Medicare Advantage landscape, at least in terms of what I've seen and worked with in my experience, and then pivot to bundled payments and the Carrum Health model for direct-to-employer contracting with self-insured employers, which is a unique perspective on bundles, and something that my predecessor employer, Northern Light Health, did with Carrum. So, is anyone here in a Medicare Advantage value-based arrangement? So generally speaking, if you go into the Medicare Advantage value-based arrangement space, you're going to probably see a few common components of it. And the first is going to be a medical loss ratio target. And that's going to have usually shared savings if you're in an upside, and shared losses if you're in both a downside. And Medicare Advantage, as you probably hear in the news, focuses a lot on HCCs and complete and accurate coding. And that's important both from a legal and a strategic perspective. And as you heard in the previous conversation, getting to know where you are, what kind of capabilities you have in place. In order to do and address the coding issues, you need to have a good process in place with your providers, with the coders and documentation to ensure that you're accurately capturing coding and diagnosis. And the MA plans, of course, are very focused on star ratings. Star ratings are attractive for beneficiaries. They also give some additional flexibilities to MA plans in terms of how they can market. And they are usually, they were just released maybe a month or so ago, the updated star ratings where some had fallen. But a lot of times, most of the time, if you're in these types of arrangements, the star ratings are tied to the metrics that you need to meet. So again, to the previous speaker with the different payers have different things. Ironically, in the MA space, you're all doing the same thing on the star rating. So that's one example where you can have things that are in alignment. And you can also have things like co-branded plans and provider-owned plans. Co-branded plans, I just worked to launch one in Maine with United Healthcare with the health system. And you can also have a path to partial and or full capitation. And you can also have another great advantage of Medicare Advantage is you can have things like additional benefits that you wouldn't otherwise have in traditional Medicare, like telehealth, food and utilities, low-hanging fruit, understanding your patient population. In the state of Maine, lots of people come to the ED because they're cold, they're hungry. We did things like deploying food bags in our primary care office spaces, which screen for food insecurity, either send them home with staple foods or help them get connected to the local food pantry and things like that. Dental and vision, those are also additional hot benefits that the MA plans will offer, supplemental benefits. And those help fill some gaps and are very important, as you might imagine. Dental is a pretty key component as you think about linking up with other types of providers because of the issues that making sure you have good preventive dental health can have on the person. So just to talk a bit more about, get into some of the legal terminology, not to go too far into the legalese, but just to make sure everyone understands when you're talking about the medical loss ratio targets with shared savings. Make sure you keep in mind that the Affordable Care Act is the one who set the MLR rate at 85%. And so what does that mean? That means that 85% of the dollars need to be spent on medical claims. And when you're negotiating these deals, when you think about having the dollars, working with somebody who can help you model what the deal terms mean for you, you want to understand, at least from the payer, how they calculate the MLR. So in other words, do the quality payments go towards the MLR calculation, or do they go somewhere else? Different organizations can calculate the medical loss ratio, and they may even have different terms for it in different ways. And also the impact of the Medicare Advantage organizations related businesses. You want to just certainly try to understand as best you can. And again, that theme of transparency, if you ask, they will give you information. Help us understand how you calculate this. Help us understand how related businesses, and again, it's not going to be all of the, all of the components, but they're at least going to give you things so that it will help you make informed decisions, because you want a position for joint success. These negotiations are not the traditional sitting across the table. We want low rates, we want higher reimbursement. It really is, how can we come together to do something differently to ensure a sustainable model? And then what is the realistic impact on the MLR? Where are you? Do you understand what HCC coding is? Do you have a process wherein you can educate your providers? Do you have a means to understand that so-and-so is coming in? Here are the diagnoses that you want to look for. Did he or she, did that individual have these diagnoses? Are these diagnoses no longer relevant? All of that can impact the MLR. So if you're at the very beginning of your journey, you probably don't want to have a very aggressive MLR target. But if you have things that have been deployed and are in progress, then you have the ability to maybe have a bit more on the upside because you're going to be able to impact that MLR. And this is just going into a little bit more detail on the hierarchical condition category coding. The rules have changed a bit. And so traditionally CMS relies on the Medicare Advantage organizations to collect these codes from their providers and submit the codes to CMS. There was a glide path wherein the plans could do, I don't want to say behind the scenes, but have an additional mechanism to feed those codes to CMS. They now all need to be on a claims file. And so if you're in the electronic claims filing world, that HIPAA standard transaction, those codes need to be captured. And if you know anything about claims, you know that not all of the codes are captured on the claims. So it's really important to kind of, pulling in the revenue cycle team or pulling in your billing folks to understand how those diagnosis codes then translate onto your claims is pretty important. CMS then takes those codes and maps them into things that take into account clinical characteristics and costs and implications, and then they get mapped to an HCC, and that determines how much money the MA organization gets from CMS. And so you really need to understand that patient, and this isn't about patient cherry picking or anything like that. It's about making sure that the MA organization is getting the accurate payment for the patient based on that patient's condition. And then that in turn would be part of the dollar pool that is available for sharing and risk sharing with the provider. And from a legal perspective, if you keep up with the news, you understand that the OIG is very focused on HCCs, and I just shared with you 2 reports that were out there. So the thing that you might hear about is over-coding, up-coding, making sure that when you're capturing coding, that you're only looking at the codes that are there and you're not, auditing only so you can add codes. That report that was issued for Humana was really to enhance the policies and procedures. And I think this is a good theme because part of the evolution when you're looking at these types of risk contracts, if you're looking at compliance policies, you really want your compliance policies to be able to follow these activities so that when a person that's in the operations gets the call, we want to do an audit, you need to make sure and different people have different perspectives. The conservative approach and the approach that we usually advise is to make sure you're looking at adds as well as deletes. In other words, you're not just looking at opportunities to add codes to the charts. You're also looking to make sure that all the existing codes are still relevant. And then, of course, more recently, the CMS issued a report about MA organizations that are denying services that meet coverage and billing rules and delays in prior authorizations. When you are working with the MA payers, their prior auths are theirs. This is a wonderful opportunity to talk to them about, for this, this, and this, you deny our prior auth, and 85, 95% of the time it's overturned. So what can we do to work together to minimize the amount of times you're going to take our prior auths and deny them? Also maybe removing, another opportunity to listen to the providers. What are really the things that drive you crazy on prior auths? Where do you maybe disagree? You can have a conversation, and sometimes, several times, you can collaborate on where you might not need to go through the different prior authorizations, as well as the delays. When you're in the MA world, they have up to 14 days. We hear about that a lot with delays to post-acute care transitions and the prior authorizations. What can you do to better collaborate so that you can make sure that that process from inpatients ready to go to SNF, for example, what can you do to get everybody, even when that patient's coming in or that they're going to need some post-discharge care planning, can you start that conversation and that process sooner so that you're not doing it the day before you're trying to discharge, and then that now you've got a bed that's being occupied that probably isn't the right care at the right place. It's because they can't get the prior auth to then go to the post-acute care. So, just to, before we transition into bundle payments, so the summary is Medicare Advantage is probably one where if there is, the payers in your area, if you're thinking about market penetration and what you can do, one of the good things about MA is the quality standards are going to be pretty similar from payer to payer because they're based on stars. There may be opportunities to address things with the payer that may be problems for your clinicians. I mentioned prior auths. Are there other things and benefits that may be offered to the beneficiaries that are more attractive? And is there an opportunity to then renegotiate your fee for service? One of the things that I do when I not only negotiate the traditional fee for service contracts, but also the value-based contracts. And it's pretty important to make sure that you're all rowing in the same direction. And some of that experience that you may have on the fee for service side can then translate into the value-based side. So collecting information, usually working with an actuary to make sure that you've got the right components and understand when the models, you have to do pro forma mock models to make sure you understand what the impact to the reimbursement is and understand what the impact to your fee for service revenue is, or at least think about what the impact to your fee for service revenue is going to be. And are you getting paid for additional things? For example, if you go into a Medicare Advantage arrangement, there may be opportunity to get payments for that primary care infrastructure. We know that MedPAC is saying put more payments into primary care. This could be a mechanism whereby you want to pay your primary care providers to do the right thing, but if they're on an RVU model, it's just going to not be, it's not going to be in their financial best interest to do so. This might be an opportunity to get an additional PMPM so that you can deploy the phone calls, the things that otherwise might not be reimbursable and have an associated CPT code to then translate onto a bill. This may be that opportunity to get that additional money. And you can also combine the discussions. If you're within the right antitrust space, you can then think about if there's some adjustment on the reimbursement side, what can you take on that fee for service reimbursement side and then put it into a quality? That's another model that's worked really well is, okay, you want us to cut our rates, but let's think about what we could put into a quality program. And let's talk about meaningful targets. The payers, at least in my experience, have been much more receptive to thinking about putting into quality targets, the places where you're just, not making any progress on what the rate should look like, but there is a different conversation that you can have on the quality. So I will pause there and give you to talk.
By the way, I forgot to say this. I want everybody to know we have over 200 people watching this virtually. So this is a big audience. So just wanted you to know that. The next provision, I'm going to ask Kristen to provide a little overview of bundles in the direct to employer space and talk about how Carrum approaches that.
Happy to. Here we go. All right, thanks. So thanks very much for having me. So happy to talk a little bit about Carrum Health and the self-insured employer space. So essentially what Carrum Health does is create a two-sided marketplace, a platform for, on the one hand, self-insured employers, and on the other hand, high-performing providers. And these can be hospitals, health systems, physician practices, single-site ASCs. And so on the self-insured employer side, what they are looking for is a solution to their healthcare spend. What they see is that their healthcare costs are going up year after year, and they're not necessarily seeing a value returned on that increasing cost. And then if you drill down even further, what you can see on an individual market level, right, is an employer may have a market where one of their employees or eligible dependents gets a joint replacement surgery for $50,000, right? That's what the plan pays. But someone else in that same market can get a joint replacement surgery for $25,000. It is not necessarily true, and oftentimes it's the case that it's not true, that the $50,000 surgery is better, right? And of course, if it's not a better surgery, if there's complications, the plan then pays more for the pleasure of that. And so they're really looking for a meaningful solution to their healthcare spend. And so then you have the other side of the marketplace, the providers. And so Carrum contracts with providers to provide a defined set of bundled services representing significant areas of healthcare spend for employers. So things like joint replacement surgery, cardiac surgery, spine surgery, but then beyond even point surgeries into oncology. So we recently started providing 2-year oncology bundles, which bundles everything from surgery, chemotherapy, and radiation. And so for the employees and dependents, this becomes part of their employer-sponsored benefit package. So this lives kind of in addition to and on top of insurance that they might get through a traditional carrier. And so essentially, we provide this contracting entry point for both sides, right? If you are an employer, you don't have to go out and evaluate and contract and manage the relationship with providers across the country. And if you're a provider, you don't have to go out and do the same, right? Trying to secure your own direct-to-employer business. And then for the employees and their eligible dependents, they can come on and they register, and we have an entire team of folks at Carrum that work with them to register them, send the referral to the provider, and manage any travel. You know, this is a model where we're not trying to replicate a PPO network. You know, so there is employer covered travel. If they don't have a COE that's close to them, the employer will pay for them to travel. The employer will also cover any out-of-pocket costs. So they waive the copay, the deductible, the co-insurance, with a little asterisk, you know, subject to IRS regulations around HSA plans. So that's kind of in a nutshell what we're doing and the role that Carrum plays, you know, when it comes to value-based care in the self-insured employer space. And so, you know, you might ask kind of, you know, you might be thinking to yourself, well, this isn't new, right? And you would be right in the sense that there have been folks doing this model for over a decade. Walmart is probably the best known example of a large employer who started doing this for their self-insured plan. But other folks like Boeing and Lowe's started doing this about 10 years ago as well. And so the role that Carrum really fills is not to invent this model, but we think to refine it and improve it, right? Not every employer is a Walmart, a Lowe's, or a Boeing, right? Not every provider is as big as a Mayo or a Cleveland Clinic that have also been doing this on their own. And so what we do is we go out into markets and we take a look at providers looking at their individual quality metrics. And so this kind of gets around how do I, you know, essentially gain access to this if I don't maybe have the name recognition or the leverage standpoint of some of these large academic medical providers. Essentially, Carrum kind of takes that on behalf of providers. So we look at the facility level outcomes as well as actually individual surgeon quality metrics. And so we look at folks at about 50 different quality metrics, looking at their experience, the quality of their outcomes, but also their surgical appropriateness and avoidance. And so the results of that you can kind of see here on the screen, right? So we're able to reduce readmissions compared to what happens in normal PPO networks. And then I think even more importantly, we're actually able to avoid a significant number of surgeries. So everyone who comes onto our platform has to have a surgical recommendation. And by sending them to very high quality providers where they have a demonstrated track record of surgical appropriateness, we're able to avoid about 40% of spine fusion surgeries and 1/4 of joint replacement surgeries. And so that's really part of the value proposition that these self-insured employers are looking for. If you kind of go back to that dilemma that employers have, which is my healthcare costs are rising and I don't see the value, this is part of the value for employers. Of course, the other component of the value for employers is we are negotiating bundles at a flat case rate, and they are typically lower than what your current negotiated rates might be with carriers. And you can get a sense, so this is just a snapshot of where Carrum is right now in terms of the density of the lives that we have. And this, I think what it goes to show, right, is when you're looking at a large national employer population, there are lives everywhere, right? And this is relevant for providers because you may be a provider in a market where there could be a very large employer headquartered. And so obviously you want to go and develop a relationship with that employer. But even though they're headquartered where you might be and they have lives in your market, they're going to have lives all over. And employer benefits teams are really exhausted, I would say right now, by kind of a continuous wave of folks coming and, trying to integrate into their plan. And so they're looking for, easier solutions that meet more of their needs. And so a network like Carrum can be helpful because you can come on as a provider and work with Carrum, get access to that employer, get the benefit of access to the lives in your market. But the employer is happy because they have coverage, in Kansas, in Idaho, where they might have other populations of their employees and dependents. Okay. So it all sounds great, but kind of what is the, what's the contracting implication of this, right? So kind of what is the product that you as a provider would be selling to an employer? And this is really the core of the bundle. Now, no need to go line by line. It's really just two components that I think are helpful to keep in mind. So one, this is a surgery-focused bundle. Obviously, this looks different in an oncology bundle covering the 2 years of care, but this is for a surgical bundle. The focus is really on the surgery and bundling all the services for that surgery. And that's a case rate that is set in advance. So as a provider, you have to identify all the various components that will be providing services under the bundle. Anesthesiology, pathology, labs. Oftentimes, these are not integrated employed elements, right? But you have to contract for them to come in under this bundle. And then you, of course, have to manage the performance of all of these disparate elements against the case rate, which you know in advance. The nice component of a bundle, like what we do at Carrum, is that it specifically excludes PT and post-acute care. And that's very different than the government bundle programs. And that is really because this is a commercial population, right? This is a non-Medicare population of individuals. They don't need post-acute care. And that's not the main focus. We're not trying to bring in everything under the sun. We're trying to deliver a very targeted cost savings and value proposition for employers. However, we do ask that all of our providers, our COEs, take on risk in a 30-day period where they are responsible for the cost of any post-op complications. So something goes wrong, someone gets readmitted, there is no incremental reimbursement. So you really have to control for your outcomes and your costs associated with those outcomes in the 30-day period post-surgery. Then the other component, which is always the hardest one for folks, I think, and Christine, you can let me know what your experience was when we did our contract, is what happens if someone has a complication and they go somewhere else, right? Employers are still looking for a value proposition in that post-op time period. We obviously can't ask a provider to cover the cost of someone else's healthcare, right? There's a complication, I go, to a different place. We can't say, well, you now need to cover the entirety of that. But there is a penalty. And so the COE will pay a penalty back based on our case rate, and that gets remitted back to the employer. And really that is, it's not trying to recoup the money necessarily because it's typically not close to the full cost of that complication treated elsewhere, but it is a signal and really showing the self-insured employers that there is meaningful skin in the game to the value proposition that the Center of Excellence is delivering on, which is at its core, high quality and a better patient experience.
Can I ask you a question
Please.
about when I was given a talk about 12 years ago? I focused on the fact that Geisinger at the time was
Yes.
offering a 90-day warranty post-surgery to charge a bundle payment. And whatever happened to that? More people do it? Do they still do it?
Yep, Geisinger is still very involved in value-based care. Absolutely. Yep, and they're still offering bundles. I'm not sure if they are still offering 90-day bundles, but I know that they are still very active in the bundle space and active in the direct-to-employer space. Yep. And you see more and more, and I think what's interesting is as time goes on, right, and at Carrum, our centers of excellence, we do work with Cleveland Clinic and Mayo and Johns Hopkins and, some of the folks that you might expect, but we also work with physician practices, single site ambulatory surgery centers. And I think it just shows that there is a real, if you kind of believe in your own value proposition as a provider, and you're confident that you can deliver on this type of a bundle model, where you really have to control for costs, you have to control for the post-op period. But if you believe in your own value proposition, there's a lot of upside, right? Because this is actually a driver of business in a way that some of the the government value-based care programs aren't, right? You're essentially taking a captive population that you're already receiving and doing different payment models on them. And this type of a program, and this is really why folks get excited about it, because we're not replicating a PPO network, you are going to not just get more lives than you would normally get in your current market catchment area, you're also going to expand the area from which you draw patients because there's a covered travel benefit, right? So we have some of our COEs where the Carrum Health business that we send them represents fully 10% of their entire book of business for the year. And those are folks that are coming way outside of their geographical area. They're coming from, many states away, they're driving, flying, et cetera. And so there's a lot of upside to growing your business in a commercial population if you can, make the rest of the program work. And I think, that kind of leads nicely to the last kind of point that I want to make, which is, kind of how can you, in a contract, make sure that something like this, which, again, it requires you to bring in downstream folks into a contract, it requires you to take on meaningful risk, how can you make sure that your organization is protected, right? And so I think it's a few different things, and this is by no means an exhaustive list, but, if I kind of, had to pick four, what I would say is, first you have to pick the right procedures, the right starting point. It's very common that we, even though we might offer 120, 150 different bundles with Carrum that you can opt into as a provider, we do not have people start with 150 bundles. They may start with a single service line, one or two service lines, where they know that, they figured out the care navigation, the patient support, they have surgeons that are not only high quality, but are also, relatively easy to work with, all things being considered. Those tend to be good starting points for bundles, and then you can always expand, right? Once you get your feet underneath you. The other component is you want to make sure that a bundled program allows you to set some reasonable discretionary parameters around the participants who will be eligible to come to you. And so we work very closely with our COEs to essentially define clinical exclusions, saying if you are an active smoker, if your A1C is not controlled, fill in the blank, you might be a surgical candidate, but not until, these are better controlled. And so our team that works with patients to refer them over to a COE, if they hit one of these clinical exclusions that COE has provided, they will not refer them until that has been addressed and optimized. And it might also just be that that person might not be a good candidate for the program for other reasons. Maybe they are not psychologically well positioned to travel for surgery, come back home and recover. There can be lots of different reasons, right? So kind of really understanding the right profile of a patient to come through a program like this, I think is very important. Third is to make sure that the contract allows for some level of risk stratification, right? And this is different than outliers. So a lot of times when folks look at a bundle payment and they look at a flat case rate, they say, this is all fine and well for the cases I know that I can make the margin on, but what happens if something goes wrong? What happens if costs, really balloon? And the hard answer that providers don't like is that's part of what you have to control for, right? So outliers are, I think incompatible with a value-based care concept, but what's not incompatible is making sure that you do not have a single bundle covering any joint replacement patient who walks in your door, a single bundle covering any, coronary artery bypass patient, right? So you want to make sure that there are different risk stratifications, different case rates that correspond to different levels of complexity of the patient. And then last but not least, if you're considering working in the direct-to-employer space, if, especially if it's a travel program, you really want to make sure that the partner that you work with, or if you do it yourself, that you can, support the patient in both the kind of the optimization clinically, the smoking cessation, but also making sure that they're supported in their travel being booked and managed, that their expectations are set, right? That they know exactly what they're supposed to do, how the program works. Because again, the kind of key to all of this is that it's a fairly routine patient population, well positioned to recover. And so you really want to make sure that that patient is optimized to go through the experience.
Yeah, and I can add, Northern Light chose bariatric surgery, and we chose some basic joints down at Mercy. And bariatric surgery was one that there's a big focus on. The system is spread all over Maine. One of the things that's happening in the market as you look is figuring out where the right sites of care are, and are you going to do every single surgery at every single site, and having to have those conversations. And while we did the bariatrics at the largest hospital in the system, that was one where we had a lot of the providers. The providers were part of the discussions. So it optimized a mechanism whereby we focused on a surgery that was one that we were positioned and, had a lot of momentum. It was also one where we had to, we were looking at, telehealth was exploding. That a lot of the work, the pre-op work is via telehealth, making sure, and that might be a surprise for some people, 2 surprises, telehealth and do you have all the specialists or the ancillaries, I apologize. So it was an opportunity to really look at and working on the telehealth strategy. In addition to making sure that you have contracts, no longer are these ancillaries billing on their own. They're included in the bundle, and now you're negotiating rates with them. So it was an opportunity, again, to have that closer relationship with the providers. And in the case of the joints, we do joints, Northern Light does joints probably all over the system. Focusing on a single site where the competition, we were not the most competitive in the marketplace. We had a large competitor. And so it was an opportunity to get patients coming in, doing something where everyone felt comfortable, and a way so that these surgeries were not being going elsewhere, whether it be to another health system or even out of state. Maine in the winter versus somewhere warmer. So patients would be willing to travel. But again, it was that opportunity where Northern Light had this very robust care management, patient navigators, all of that good stuff in place. And again, the telehealth component, and it was just really seamless and was a really good experience.
Well, and Christine, I thought another thing that you did really well at the organization is you had a very, I think, common but tricky situation where in a service line you will have a mix of employed and independent surgeons, and then the question is, who gets to participate, and how do you manage, where do patients go? And so I think, bringing the surgeons in at the right time and socializing it and not having it be a surprise, especially in a situation where there's a mix of employed and independents, is incredibly helpful. And I think that's also where, a company like Carrum can actually be a little bit of a helpful bad guy, because we end up being the ones who finally decide who's certified. Right. So it's not the provider organization. And so that can also be, I think, very helpful, because there's a lot of organizational dynamics that go into setting up a program like this.
Okay. Yes. Yeah, sure.
Yeah, I'm sorry, I'm not following. Carrum contracts with a group of providers or a health center.
Yep.
And then they work in establishing the centers of excellence.
Yep. So Carrum is essentially I mean, it sounds so bad, but it's true. It's a middleman for lack of a better term. So we have a contract with the self-insured employer. We then have a contract with a single contracting entity, which is either a hospital, health system, physician practice, surgery center. And then that contracting entity is then the convener for the bundle. So we have a case rate in the contract between Carrum and the convening entity. And then for any provider that is going to be involved in delivering care under that bundle, it's the contracting entity who has to go out, do the downstream contracts, do the downstream payments, and essentially convene the bundle.
Let me ask a question. Well, let me just go over this and then we'll have time for a few more questions. What about providers who actually are not focusing on this because they sticking with their fee-for-service agreements because they see they're getting high reimbursement, they're not noticing volume shifts? Well, what are your thoughts for them?
So
You think that's going to continue forever? And if not, what they should be doing to start planning for when it doesn't?
So I can offer from at least from the health system perspective, I think that part of what we're looking at here is an opportunity to do one certain thing, right? One thing that you do well. The nice thing with the bundle approach was being able to shine in an area where you already have clinical excellence there. The other piece, of course, is looking at what your fee-for-service contracts are currently paying. Are you hearing from the payers that you are too expensive? Is there an opportunity to perhaps think about adjusting those rates, either converting that contract if you're so bold as just want to go in right into fixed payments, converting it on I'll say revenue neutral basis so that you get that fixed payment component if you're really ready to address the cost and quality necessary to be able to deliver services within that fixed payment model. So those would be some of the things I might suggest.
Yeah. I mean, I think, so I hear that, all the time, right, from providers, either, and I think it can be one of two things. It's either we're in a market position where we don't feel like we have to, right? We have high market share and we have great managed care contracts, call us when that changes, and honestly, I can understand that, right? And then I also run into providers who maybe they, tried it in the past, right? There could be solutions that come in, they make big promises, right? And then there's a significant delta between the expectations that the provider organization had for that bundled payment or value-based contract, and then the business that it was actually, came of it. And so that is, kind of the once burned, twice shy. And so, and in some ways I almost prefer the folks who are, still living in the fee-for-service, fantasy, because it's, you can at least kind of try from scratch. When folks have tried it and it hasn't worked, it's really challenging. And that's where I think you really have to dive into being very specific and transparent about the data behind, this program, how it works, and hopefully how it's, different. The reality, though, that I think that, even if it hasn't been successful in the past, or you feel as though the market pressures aren't acute enough that you need to do it, I mean, I just see what I see our demand side doing, which is our self-insured, clients. And so this is where you really see market forces at play. These are ultimately the purchasers of the healthcare dollars. They can make their own decisions about what they want to do with it. And so, a few years ago, we had almost every single one of our clients at Carrum on a model where, sure, they would offer this center of excellence as part of their benefits package. Folks could come on and use it if they wanted to. Now, of course, if they used it, they had no out-of-pocket costs, so they could get their surgery for free. They could have their travel covered. So it was more of a kind of a nice, a nice to have, something to really enhance the benefit package. I think because those cost pressures that employers are seeing around the cost of healthcare, and again, their frustrations around the quality of healthcare, what employers are increasingly doing is moving to a model where it is no longer a choice to have your surgery through Carrum. They're actually carving out and mandating that in order to have your surgery covered at all, you have to go through a Center of Excellence program. So you will not, if you need a joint replacement, if you need a spinal fusion, it will not be covered under your PPO plan. You have to go through. And I think that kind of hard steerage, and I know steerage is a little bit of a, kind of dirty word in healthcare, but that's really what it is. It's a hard steerage into this model. And so then if you kind of go back to that one provider then who's sitting with 60% market share, really competitive managed care rates, it's no longer just do we want to do this because we think we're going to win more business? We're going to do this because otherwise we're going to lose business. And so it moves from kind of an offensive, let's take advantage of it, into a defensive strategy. And that's where we see our book of business in terms of our self-insured clients. That's the direction that they're going.
Yeah, Paul,
Yes, very excited about what they're doing and, the glee that they're trying to bring forth in this self-insured employer.
Mhm.
So I had the wonderful misery to deal with AT&T for about a year trying to bring fiber to my medical bill.
hey, Paul, could you, if you walk up to the mic,
Sure.
everybody will be able to hear you.
So continuing, once again, very nice job about Kristen doing this explanation. Self-insured employers. From my understanding, there are more self-insured employers leaving that position than going into it. And the misery that I was talking about was dealing with AT&T, and through that cycle, of about a year bringing fiber. Simple process, but AT&T can complicate anything easy. So during that time, I went through a period where I was dealing with this AT&T and he was doing a great job for me. And then all of a sudden he says, we're not able to do this anymore because I'm leaving AT&T. They have bought me out. They figured that my age of 55, between 56 and 64, they're going to save a lot of money if they get out of self-insuring. And so he left, and all of my 6 months of work was dumped. There are more self-insured employers leaving than coming in. Is that true or no?
So I don't see self-insured employers necessarily moving and becoming essentially giving that up and going to fully insured products. I don't see fundamentally self-insured employers, not self-funding their plan. What I do see is much more willingness, I would say, in the past 2 years for self-insured employers to make big moves around who gets their administrative services contracts, right? So, even if you're self-insured, you still have an insurance company where you're, accessing their PPO network, they're doing the claims administration, appeals processes, all of that. I see, and I've been really surprised by this, more and more, large employers who are willing to leave their traditional ASO contracts and go with even smaller third-party administrators because they're so frustrated by some of their experience. And so if that happens, right, if they switch their ASO and all of a sudden, that person, has a different network configuration, I think you can see disruptions that way. And it certainly is disruptive. But there's definitely movement in the self-insured employer space to switch carriers, and I think much more willingness to and kind of appetite to do that.
Any questions coming from the virtual attendees? Any other questions in the room? Well, if not, thank you very much, Christine and Kristen, for an excellent presentation. And we'll move on to our next topic.